Assalamu alaikum. This is Lina Al-Kahmous from KCASH. I'll be talking today about the clinical manifestation of the superior oblique and how to differentiate between the unilateral, bilateral, congenital, and acquired. So we all know that the superior oblique muscle is the only muscle that is innervated by a single nerve, and its anatomical pathway and course make it very vulnerable to damage. It's the most common form of isolated cranial nerve palsy, and it can be unilateral, bilateral, it can be congenital, and acquired. So here's the basic, this is a table that gives you a hint how to differentiate between the congenital or a long-standing superior oblique palsy and the acquired in clinic, and that's how we use it in orthoptic actually. So in long-standing cases, you would find a facial asymmetry usually, a stretched vertical amplitudes. You would find a full muscle sequela where the underaction of the agonist, overaction of the ipsilateral antagonist, overaction of the contralateral synergist, and underaction of the contralateral antagonist. Usually, with the congenital cases, you'll find the full muscle sequela. Sometimes you find it with the first two steps only. Neck pain due to the long-standing as well. This might not be found in acquired. And stereopsis with the AHP if present, or they might develop suppression. Where in acquired cases, you would find diplopia usually. AHP may or may not be, depends on the onset of the case, of the damage. And the past pointing, where the patient loses the depth of perception, so they wouldn't be able to detect the place of the object due to the losing their stereopsis, where the congenital cases would use their monocular clues for this. Here are some points to differentiate between the unilateral and bilateral superior oblique palsy, and this is orthoptic-wise. So in the unilateral cases, we usually would find a huge vertical deviation in primary gaze, and the torsion is really minimal, no patterns usually, and it doesn't usually come with trauma, where the bilateral cases, you would really find a lateral lateral of hypers, means on left gaze you would find a right hypertropia, on left gaze you would find the opposite, and that's in all gazes and in all positions. Left tilt, right tilt, it's all the opposite. So it's the reversal of hypers. This is a big sign of the bilaterality, even if it's asymmetrical. So you could point to a masked bilateral superior oblique due to this reversal asymmetry, of hyperopia. And the torsion in the bilateral superior oblique would be greater than 10 to 12, where it's less in the unilateral. Bilateral comes with a large V pattern, and it's very common with trauma. So whenever there is a trauma, suspect a bilateral superior oblique. This is a case of acquired bilateral superior oblique. We'll notice here, it's not clear, a large V pattern. If you can notice from the upper primary gaze and down gaze, where the difference between the up measurement and the down gaze measurement is 20 degrees, 20 prism diopters, sorry. We counted a V pattern when the difference between the up and down is 15 prism diopters or more in V patterns. And you can find a reversal of hypers, right gaze and left gaze. There is an LHT in right gaze and RHT in left gaze. You can also notice, well, actually, we didn't notice this. The double Maddox-Strode shows 15 degrees of right axial torsion. This is the Hess chart of the case. A Hess chart would It's a great, actually, diagnostic test to lead out to give us an idea about the diagnosis and the follow-ups and improvement or regression of the case. Here you would see a huge underaction of the agonist, and you would see the full muscle sequelae in the Hess chart form. Sorry, Hess chart. I'm sorry, I can't explain without the pointer. So, and usually the inner box, when it's not affected, the more affected inner box is the actually more affected eye. So this is what you can find out from the Hess chart. And we usually follow the muscle sequela, which is under, which is over. In the Warford test, in this case, we had cross diplopia, near and distance. So this is a typical acquired bilateral superior oblique palsy findings. This is another case of unilateral acquired left superior oblique palsy. You will find a small torsion, or actually we found a small torsion, and there is a huge vertical deviation at primary gaze, as you can see in the middle, where there is a left hypertrophy of 25, and no V pattern, no reversal of hypers. So this indicates a unilateral superior oblique palsy. Also, the Hess chart would show one muscle involvement and the muscle sequela as to give a full picture of the diagnosis. This is the Synoptophore slides, where we can in Synoptophore we can one of the tests that we can do is the binocular single vision. We start with the simultaneous perception, then the fusion, then the stereopsis. That's what we test in Synoptophore. And in this case, we could reach the level of fusion. And so this is what the patient could see at the left over right of 31 prism diopters. So he got fusion at that point. And this is good as a post-diplopia test as well for surgical implementation. So these are basically the orthoptic tests that we use usually to diagnose paralytic cases in clinic. Belchowski test, which is the 9 gaze, Synoptophore, the prism cover test, Hess chart or Lee screen, double Maddox Rod, and the post-diplopia test. That's all what I have for you today. Thank you.